The next topic is innovations and management in diabetes eye care and overview. The speaker will be Dr. Vikram Singh Bhutoria, who is a consultant ophthalmologist, director VSB eye care, and the chairperson will be Dr. Richal Kumar, who is a consultant ophthalmologist attached with Narayana Hospital.
Good evening. I think some hot tea is waiting outside, and I am not the right person. We have a VR surgeon of repute who is there in the panel. She should be speaking about this, not me. So I want to make this very simple because diabetic retinopathy is too huge to be covered under one place, in one head. We have one full conference dedicated for that. Now, what is simplifying? Simplifying is, I'll just relate a small episode about Albert Einstein. So we all know Albert Einstein was a physicist of great repute, and he was a Nobel Prize winner. But he won his Nobel Prize because of photoelectric effect, not because of theory of relativity, which was his main theory. Once I was sitting in a village, and there was this old lady, barely literate. She said, "Look, I've heard about theory of relativity, and scientists have not been able to understand it. Can you explain it to me?" He said, "It's very simple. When you're sitting on a hot stove, 1 minute is like 1 hour. And when you're sitting with your girlfriend in a park, 1 hour goes like 1 minute." So that is where we simplify these presentations and, make it easier. So for such diabetologists of repute here, how can we as ophthalmologists, help you in this treatment and this management? So, predisposition, you know it much better than I do. The three problems of diabetes: hypertension, dyslipidemia, hyperglycemia. Symptoms. So patients will come to you with dimness of vision, sudden increase of floaters, little bit of dimness of vision during night. Most important is distorted vision. Distorted vision will only happen when the macula is getting involved. When you have a submacular accumulation of fluid, or somewhere or the other it is getting, the architecture is changing, so the image being printed on the macula is distorted. So that is something which you actually have to look for or hear for from the patient. Now, if we come to the basic pathophysiology of diabetic retinopathy, it's abnormal vessels, and abnormal vessels. So if you look at this small picture, it's not very clear. So in diabetes, this abnormal vasculature is which creates all the problems. It might be neovascularization, it might be venous bleeding, it might be hemorrhages, it might be aneurysms. It is all about the vasculature. So if you come to the types, this again is a VR subject. So we have a non-proliferative diabetic retinopathy where it is the earlier stage where we can actually intervene in a much more effective fashion, followed by the more aggressive proliferative diabetic retinopathy. The basic difference is neovascularization. So in a NPDR or a non-proliferative disease, there is no neovascularization, it's absent. In the early stage, you might find one microaneurysm in the fundus. You go to the moderate stage where you'll have multiple microaneurysms, you'll have some hemorrhages, you'll have the veins will be bleeding, and there'll be a few cotton wool spots. Now we can come to the severe non-proliferative diabetic retinopathy where you can use the rule of 4-to-1 where the 4 quadrants having more than 20 vascular abnormalities is 4. 2 is venous bleeding is seen in 2 or more quadrants, and 1 is the IRMA or the intraretinal microvascular abnormality which is seen in any one quadrant. Now, there's a difference between the IRMA and a neovascularization. Again, that is the domain of Dr. Richa, not mine. So, PDR is the most advanced stage of diabetic retinopathy. Here, the only thing is neovascularization. This is not a very good thing. Difficult to, predict how it will progress. Difficult to treat. Patients are not very happy. Now, comes your part, the management. Ophthalmoscopy, imaging, and in ophthalmoscopy we have direct ophthalmoscope, the indirect ophthalmoscope, and the slit lamp imaging or the slit lamp examination. The direct ophthalmoscope is something which you've all seen. This one. It's a pocket ophthalmoscope which we all used to carry when we were students, and most medicine colleagues of mine do carry this. But then after COVID, we don't, we don't use direct ophthalmoscopy nearly at all. Indirect ophthalmoscopy is where you have a headband and you have a 20 diopter lens with which you can actually see the fundus. It gives a much wider view of the retina. Slit lamp evaluation is even better, gives you a three-dimensional view because you're using both your eyes, and it's much more clearer and much more diagnostic if you look at it from your angle. But then, problems. Direct ophthalmoscopy is easiest, as I said, but after COVID, you can't have this. You have to maintain your distance. Indirect ophthalmoscopy, again, it has a learning curve. It needs a separate instrument. Slit lamp examination is very good, but then you need a slit lamp in your clinic, which will be very difficult to provide for. So what is better? OCT, very good, very nice, nearly diagnostic, gives you the exact structure of the macula. This is a classical macular edema. But then the problems with OCT is, it is very expensive. In order to make it viable, you must have at least 50 to 60 or maybe 100 OCTs a month. OCT, is optical coherence tomography. I mean, we are so used to. There are cheaper options available now. The Indian ones have come up, which are, let's say, 1/3 the price. But then, do you need an OCT in your clinic? I would not suggest it. As diabetologists, I mean, if you do all this, then what will we do? Difficult. So what is best for you? Now comes the era of photography. Artificial intelligence, as Dr. Amit Dey was talking about. Whatever you do has to be easy to operate. It should be able, your assistant should be able to do it. You don't need to sit on the table. All you need to see is the photograph. And the ease of sending images to your ophthalmology colleagues. Oh, it's already? Oh no, it's not mine, sorry. For mobile photography, again, it's very easy. You can simply put it on the slit lamp and take a photograph, but then you need a slit lamp for it. And the AI is not incorporated. I am so sorry, this is stupid of me. The AI is not incorporated. So where do we go? Now we come to this thing called fundus photography with artificial intelligence. This is the game changer. This is something which you can actually keep in your clinics. I just have one slide, and I'm not financially interested in this company or the sale, but this is the only one I could get from him. Here, the fundus photography has been taken, and the machine has detected which stage of DR and what to do with this. This photograph you can mail to your ophthalmology colleagues. This photograph you can actually, it helps you diagnose and treat the patient accordingly. And then, what would be the basic management? As our teachers taught us, you kill the ischemic retina, because ischemic retina produces all the factors which add to the microvasculature happening, the abnormal vessels happening. So how do you kill the retina? You actually use lasers. This is seen in proliferative diabetic retinopathy, where you actually do lasers, if I'm not mistaken. Then you have something where you can take care of the ischemic factors, which are anti-VEGFs. These are the new things in town where we are using them. Not I am using them, she is using them, hugely. And you have intravitreal steroids, and of course the vitreoretinal surgical procedures, which are the last stage probably, or maybe somewhere in the towards the end side where you have to do surgeries. In anti-VEGFs, only two things are in common. One, of course, they are all anti-VEGFs. And two, they are absolute tongue twisters. So if you have to try to read these 4 names of anti-VEGFs, you will understand why I am saying they are tongue twisters. It's impossible to pronounce them. I'm sure the person who named them had some problem with himself. And I don't know why they named them this way. Bevacizumab, ranibizumab, this is like poetry. So with this, I'll probably end up, this small thing, and we can all go and have tea. So thank you very much, and we want justice.
So thank you so much. And just a few more things I would just like to add, like diabetic retinopathy is really very prevalent among the diabetic patients. Approximately 67% of the patients with type 2 diabetics within first 10 years of diabetes, they develop diabetic retinopathy, and that to 10% develop proliferative ones. So it is very important to send them for screening. Now there are several types of screening. First is hospital-based, which we really do. Physician-based and ophthalmologists are doing. Second is community-based, like AIOS and OSWB, they are quite frequently doing it, mass screening of diabetic retinopathy. Third is telemedicine. Telemedicine, what happens that there are several institutes which are doing over here, like just we were discussing some time back.
Here I'd just like to add one small thing. So I work with this Lions organization. So Siliguri Lions has a huge telemedicine setup. They send the van to the villages where they pick up the pictures and send it to the mother hospital where the ophthalmologist or the VR surgeon will take a look at the pictures, and there they can pick up the patients who need management and those patients who don't need management. So the whole group of diabetic population does not have to shift to the hospital and go back.
Exactly. So it's actually, it's
very helpful.
Very helpful. So only those patients which come up to very mild NPDR or more than mild NPDR, that is moderate level, only they need to be referred to the eye specialist. Otherwise, they need to be screened after 12 months. That is the protocol. But then there were some disadvantages leading to, in this telemedicine thing, leading to this image quality of image. So this AI system has now come where there is a reduced time interval, like within 30 seconds the patient can get their reports done. And am I right?
And also the newer cameras don't need them to dilate the pupils.
Non-mydriatic.
The non-mydriatic cameras have come. So this whole thing about, as Dr. Amit Dev was talking about, artificial intelligence. So here artificial intelligence is now being used to, to widen our sphere of catching more patients who are susceptible to develop diabetic retinopathy. And then if we send all patients to the VR surgeon, she will not have time to eat. So there has to be, the referral has to be graded. Yes, this needs a VR opinion, this does not need a VR opinion.
Exactly.
And there will be some gray areas where she will have to be called for. But then early NPDR does not need a VR opinion, where you just need to control the diabetes and modification of lifestyle.
Modification, that's it.
Right, sir. So this reminds me of so definitely there is a role of genetic factors, because I remember when we were students, our professor taught us genetic predisposition is there from common cold to retinoblastoma. So there is definitely a genetic predisposition where maybe there are some genetic aberrations where the patients might develop diabetic retinopathy more. In fact, I have seen patients coming up with PDR or a proliferative diabetic retinopathy after 5 years, whereas normally we expect 10 years or more of diabetes. Of course, the lifestyle factors, the uncontrolled blood glucose, all these are factors. But yes, you're right. There are some patients who are more predisposed to this condition. Genetic or not, again, that's a question of statistics. Sir, I have seen, yes, but then if you ask me whether I have statistically, everything now is statistically, area under the bell curve. The clinical, yes, I have seen patients whose parents have had diabetic changes in the eye. The offspring have had an earlier change, but then again, the other factors, pan parag, smoking, those factors also come in. Parents did not have that factor. The younger generations are a little more aggressive regarding these bad habits. They are more prone to it. So then again, boils down to statistics, area under the bell curve. So, ma'am, you want to?
That's it. Any other questions?
Thank you, Guru. One thing. Yeah. Yes. Yes. Very rapidly, yes. Sir, he needs to be screened by her, the VR surgeon. I would say every 6 months. Because if he is starting to develop diabetic changes, then she will treat the brother much more aggressively than she would treat some other patient without her CKD.
Other than genetic predisposition, most important is systemic control.
Yes.
Not only sugar, other like hyperlipidemia, then your urea creatinine level. Most of us, in fact, I have seen in my own practice that one post-renal renal transplant patient, he did so very well after transplant patient. His like proliferative, he had proliferative thing, and he did very well after post-renal transplantation. But there are a few drugs that causes worsening of diabetic retinopathy also,
Yes.
like pioglitazone, semaglutide, that causes worsening of diabetic retinopathy.
So again, as I would, bring it back, it's impossible to put together, in one small lecture. So, but then my take-home message would be the use of telemedicine, artificial intelligence to just make sure we don't miss out on these patients. That I think is the most important thing for diabetologists who are practicing. Yeah.
Okay.
Thank you.
Thank you. Yes. No, it's not it that causes diabetic retinopathy. Actually, it's on experimental level. There's a focus trial on that. Semaglutide leading to worsening. 1,500 participants are there, and it will be completed by 2027. So right now, only two hypotheses is there. Firstly, semaglutide is not a first choice drug. Often it is seen that when it is uncontrolled diabetes, patient gets switched to semaglutide. So they are already having poor glycemic control in that case. So first one is that. And secondly, as we all know, even in Kansky it's written that if there is sudden control of glycemic index, sudden control, that leads to worsening of diabetic retinopathy. So these two are hypotheses. It's not proven yet. But yeah, it is there that after 12 to 18 months, it leads to reduction in the progression of diabetic retinopathy with semaglutide. Okay, thank you. Thank you, sir.
I'd like to invite Dr. Guru Prasad to felicitate the speaker and the chairwoman. Dr. Guru Prasad and Dr. Bishwa Kumar to felicitate the chairperson and the speaker.